The Topazio trial was very interesting because it took a look at patients with BRCA mutations and also BRCA wild type patients, and the addition of a PARP inhibitor, which is to some extent a targeted therapy, but also can cause DNA damage, and adding that to an immune therapy. And what we saw was that in the BRCA mutation carriers, the response rate was likely pretty similar to what you would see with a PARP inhibitor by itself. But in patients that don't have a BRCA mutation or don't have homologous recombination deficiencies as they were defined in the trial, the response rates were significantly higher than you would see with either one of the agents by themselves. And so in that population that may not have a genetic predisposition to responding to, say, PARP inhibitors, you may see a benefit for adding a PARP inhibitor to immune therapy. The Mediola study was looking at olaparib in combination with immune therapy in patients that had germline BRCA mutations and had platinum-sensitive disease. And they stratified their patients by the number of lines of therapy that they had previously received prior to going on trial. But what they saw was the response rate was fairly high. It was 75% or so in this patient population. And for patients with recurrent ovarian cancer, there are very few trials that we've ever had that have had that kind of response rate, even in the platinum-sensitive setting. And so I think we're all very excited about being able to identify a certain population that may respond very well to these therapies.